Hello everyone, welcome to this Listen to Ulcers sessions by the KGR. I'm Dr. Hwang from Korean University Anam Hospital. Today, I'm excited to share our recent research titled Left Atrial Time to Peak from Time Resolved MR Angiograph as non-invasive indicators of the left atrial pressure. Firstly, let me begin with the clinical background. Left atrial pressure, LAP, is a critical hemodynamic parameter. So when LAP is elevated, it drives the structural remodeling of the left atrial structure. So high pressure actually drives the development or maintenance of the atrial fibrillation, even after successful catheter ablation. Simply, if you want a successful management of the atrial fibrillation, you may need accurate assessment of LAP. So you can have a question, how is LAP measured in clinical practice? The gold standard is a catheter-based measurement with the transeptal function of the heart. So even though it is very accurate, this approach is very invasive. So this inconvenience motivated our study. We focused on the time resolved MR angiogram, kind of a pre-procedural imaging for the catheter ablation. This TR-MRA generated dynamic sequential images of the control enhancement within cardiac chambers. From these images, we can derive the time signal intensity curve from the left atrium. Our theory was simple. For example, high LAP risks the impaired atrial emptying. This caused the delayed contrast clearance within the heart chamber, which should show prolonged time to peak in the left atrium on the MRA. To test our theory, we conducted a retrospective study of the 501 consecutive patients who underwent both the MRA and the catheter-based LAP measurement. After applying our inclusion criteria, we selected the final cut of the 92 patients. Using a cutoff of LAP 15 mm mercury, we divide the patient into two groups. Within this group, 24% had a high LAP, defined as 15 mm mercury or higher. In our study, the time resolved MRA was performed on the 3 Tesla MRI system using a 3D twist sequence. We define TTP as the time interval from the onset of a control enhancement to the point of the peak signal intensity in the left atrium on the MRI. Next, let's look at this TTP maps from the MRA and compare them in practice. On the left, we have a 55 years old man with a low LAP, 14 millimeter mercury. His TTP was 14.2 seconds. In contrast, on the right, 14 years old man with a high LAP, 24 millimeter mercury. He shows the slower TTP of the 23.8 seconds. This visual difference of the TTP map is quite striking. Next, when comparing the result between the two groups, the LAP, high LAP group was slightly older and had a higher prevalence of the hypertension. But the most significant difference was the TTP. 16.9 seconds for the low LAP group versus 25.1 seconds for the high LAP groups. There was a very significantly difference. Next, we look at the univariate correlation between the LAP and the TTP, and we found a moderate to strong relationship between them. The correlation coefficient was 0.69, which tells us that as the TTP increased, the LAP also increased as well. Now let's talk about the diagnostic performance. Our ROC analysis showed the AUC of the 0.8 indicating good diagnostic performance. We found the optimal cutoff for TTP greater than 19.6 seconds for identifying the high LAP. But the most variable finding was the negative predictive value, 96%. This means if a patient has a TTP of the 19.6 seconds or less, we can very confident they don't have elevated LAP. This analysis method from the time-reserved MRA has several good points. The main advantage is that it requires no additional imaging. TTP can be calculated from the database we already collected, and it can capture the hemodynamic changes before structural deformation, such as a left atrial enlargement. And finally, a high negative predictive value, 93%, enable confident exclusion of the elevated LAP. It looks very attractive. Of course, there are limitations. This was a retrospective single-center studies with a relatively small sample size. And we also didn't have post-operation follow-up data, which is a key direction for the future placenta studies. In conclusion, time-reserved MRA-derived TTP adds the time interval to reach the peak of the signal intensity of the left atrium after contrast injection. This TTP shows the independent association with the left atrial pressure. Using the TTP, high negative predictive value 93%, reliably identified the patient at a low risk of the elevated LAP. So we believe TTP may be a functional hemodynamic biomarkers to identify the left atrial pressure status before the catheter operation. Thank you for watching this update from the Korean Journal of the Radiology. Thank you very much.